When you say stand behind those other commentaries, so you're saying that their stance is consistent that HRT is safe under most circumstances to take. I just want to
Yeah.
make sure our listeners are clear on what.
Yeah.
All
And,
right.
and to further clarify as well, claiming that we have enough evidence for it, it to be kind of this fix it all pill for multiple different things and that it's always right for everyone in every scenario, which is it's having a hot moment, is not, it's not valid. And I am obviously a menopause expert and a hormone expert, but I don't use it for every single woman that walks through my door. And so understanding the pros and cons of when it's the right thing, when it's not the right thing, as opposed to a lot of what's happening on social media is more of a claim that, we can fix everything with hormones. It's not true. And additionally, the other thing that is really hot on social media right now is vilifying birth control. And so one of my big takeaways from the meeting was really that a lot of the other experts and a lot of the data and the evidence we have so far really justifies using it in the right people at the right time. And everyone else feels a little bit frustrated that it's again making a go around of being vilified on the internet.
So when you were talking about birth control being vilified, can you give us an example of who it would be right for and maybe who it would be wrong for, or maybe it would be time to move on to menopause hormone replacement?
Yeah, and so I love that question because it really is, it's very specific to each individual woman that walks through the door. And anyone who really truly is a menopause expert knows that each individual case, each individual woman's life and body and all of those things have to be taken account with her specific kind of plan that you're making, whether it's medications, hormonal, non-hormonal supplements, etc. And for a lot of women, birth control really is a phenomenal answer to treating perimenopausal symptoms. As you guys know, perimenopause can start as early as in someone's 30s naturally without it being, associated with any other negative things. And unfortunately, until you go past those 12 months of having no menstrual cycles, it is possible to ovulate and get pregnant. So, in someone who doesn't have another form of contraceptive or has really terrible periods, contraceptives are an amazing tool. Particularly for people who are in perimenopause, who are having irregular cycles that are specifically more frequent, heavier, life disrupting, uncomfortable. Suppression of ovarian function is a really amazing way to keep that, period or menstrual cycle under control while at the same time treating the symptoms of what is associated with perimenopause or menopause. Because a common misunderstanding is that it's only when estrogen bottoms out that women are symptomatic, and realistically it's what the scientists call like the delta of estrogen. It's the change in that level, and in perimenopause it's going up and down really willy-nilly. And preventing that from happening or controlling the cycle, controlling the ovarian function is really what makes so many women feel a lot better.
Another thing that I heard that came out of the Menopause Society meeting was their reiteration on the stance of dementia and HRTs. Because, like you said, there's a lot going around social media right now, and a hot topic is to say, well, HRT is preventative or proactive in avoiding or decreasing your chances of dementia. Can you talk about what they discussed and their stance?
Yeah, so mainly the position kind of holds that we don't have enough evidence to prove or disprove that fact. While we have, if you've taken a look at the 2002 Menopause Society guidelines, back then it was still called NAMS, North American Menopause Society. At the time that that statement was made, it was noted that menopausal hormone therapy started after the age of 60 or beyond 10 years of becoming menopausal is potentially associated with increased risk of dementia. I'm not sure that we have data to say whether or not that's true yet, and that's the problem, is that we just don't have that clear information yet. Now, if you're paying attention to social media and media in general, you'll know that Dr. Lisa Mosconi recently came out with some fantastic research and a fabulous book, which does a really good audible read in the car if you're a driver like me. But it demonstrates a lot of the things that have come out of the work of people like Jadine Hoffey and Rebecca Thurston, looking into the MIS flash studies where we look at the MRI images of the brain, showing that the more hot flashes somebody has, the more white matter lesions that they have, AKA, for the non-scientists on the podcast, basically little tiny mini stroke looking lesions. And typically that is what we see when we're talking about somebody who has vascular dementia. Is it the chicken or the egg? We don't know. It is suspicious to a lot of us in the space that the more women have hot flashes, the more likely they are to have these lesions on the brain, and the more likely they are to end up with some sort of cognitive decline or dementia. But again, is it the flashes? Is it because they were already prone to these cardiovascular vascular events? We don't really know. And so while the data is investigating that, we can't honestly say we know whether or not hormone therapy prevents it. In fact, they're now looking into whether or not treating the vasomotor symptoms, the hot flashes, night sweats, with anything such as our two newer medications that we talk about a lot with Bayer and Astellas coming out with some cool new stuff. Whether or not even just using one of those to treat the vasomotor symptoms is going to be protective for the brain. We just don't know. Menopause and the vasomotor symptoms, the sleep issues, everything that is associated with menopause is still looked at as a bothersome thing and not a life-altering, life-threatening, disease-inducing thing. And while that is for some women true, for some it's very untrue. We know that just going through menopause in general is putting you at an increased risk of metabolic syndrome, high cholesterol, high blood pressure, type 2 diabetes, insulin resistance, a slew of other things. And just that fact alone, I think, gets looked over when we're talking about these medications for what appears to be a little bit more lifestyle, despite the fact that we know that poor sleep is associated with like a bajillion things, such as weight gain, metabolic syndrome, et cetera, et cetera. And so the disconnect that had happened, in my opinion, between, kind of the FDA and the payers understanding fezolinetant and this other upcoming one from Bayer, elinzanetant, they're not to fix a bothersome problem. They're to improve quality of life and functionality for these patients. You guys know as well as I do that some women lose their jobs because of their hot flashes, night sweats, the cognitive decline that comes with not sleeping for days or weeks or months on end. And just being overall run down after those things. I have women every single day come into my office, that are CEOs of large companies or small business owners or, moms of small children, and they all come in crying, telling me, I can't function, I can't do this, everything's a mess, I feel like a failure, yada, 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 whatever phrasing that she uses. And to call that bothersome when it's showing up as, what did we say, $26 billion in the American fiscal loss in a year because we can't keep women in the workforce and we can't support them through menopause is just a complete disconnect to me.
I saw something today, just right before we came on here about maybe hormone therapy reducing insulin resistance. And I was curious if that was talked about at the Menopause Society meeting, or what are your thoughts on that?
Yeah, so if it was spoken about, it was like directly, it was not in a meeting that I was
Oh,
in.
okay.
It totally could have been. But there's a lot of congruent things that happen at those meetings.
Sure.
That is data that we've had for a while, though, that there is some association with insulin resistance reversal with menopausal hormone therapy. When you take a look at a lot of the data over the last, like 5 years, it's been booming. But even prior to that, menopausal hormone therapy has been associated with improvements in a lot of kind of the metabolic functions. So if you are unfamiliar, estrogen depletion that comes with menopause and even the fluctuations that are occurring in perimenopause are highly, highly associated with increasing insulin resistance, increasing of LDL, your bad cholesterol, increasing its inflammatory little brother ApoB, as well as decreasing the functionality of HDL, your good cholesterol. So all of those things are things that we've known for a while. I think it really kind of showed up a little bit earlier this year. I believe it was in the spring when we started getting the studies that women who went on menopausal hormone therapy and a GLP-1 were significantly outperforming those who were only on GLP-1 from a weight loss and a A1C improvement. So I really have, found that data to be super interesting, especially when, another thing that's being vilified is these GLP-1, GLP-I medications that are helpful for so many, knowing that, it really does help with hormone, being combined with hormone replacement therapy or hormone therapy.
But we dive a little bit into more what you were talking about with cholesterol and the HDL and the LDL, because I don't think a lot of women realize the relationship between menopause and your cholesterol and what's a good cholesterol number. Can you talk a little bit more about that?
Yeah, so we have had data that menopause is an increased risk factor for heart disease for probably many years now. However, the American Heart Association only came out with kind of that statement in 2020. And so in 2020, the American Heart Association came out with that statement saying that not only is early menopause associated with an increased risk of heart disease, but regular, normal ages of menopause are associated with that. And that really stems from estrogen's role in the blood vessels. And so in the blood vessels, when they lose estrogen, the actual walls of your arteries become more stiff. So things like blood pressure going up, because you're kind of working against a really stiff hose, it can't flex or bend the same way. It gets a lot of resistance, pushback, and blood pressure goes up. Additionally, on top of that, lack of estrogen is just a very pro-inflammatory environment. And so things like ApoB, which is a subparticle of LDL, the bad cholesterol, that his job is essentially to act as like the one who like calls the people over for like the house party when mom and dad leave. He calls all of his inflammatory friends and says, hey, go make something sticky and gloopy that sticks on the side of the artery wall. And in addition to that, the loss of estrogen also is associated with decreased functionality of HDL. HDL is our good cholesterol. His job is to act like a scavenger, or he's like the cop that shows up and is like, oh, hey, there's too many people. There's a noise ordinance thing. Like, let's get you guys out of here and take some of those away. And just going through menopause and having those couple things happen where your arteries are stiffer, there's more junk in them, and the stuff that's supposed to get junk out of them stops working quite as well, is a really risky environment for heart disease.